estimated 11 million Americans suffer from heart valve disease. The older we get, the greater the chance of developing something. Comes with age, affecting 1 in 10 adults over the age of 65. OSF HealthCare is at the forefront of some of the latest heart valve treatments.
None of us really thought, even 10 years back, that we could be doing this. But, the more you do things, the more you realize there is so much more to be done. We didn't know that this could be done. And now we know that there are so many things that we actually don't know. So it's an humbling experience.
That's Dr. Sudhir Mungee, and I'm Shelli Dankoff, your host for OSF HealthCare Accelerated. We appreciate you tuning in and remind you to be sure to subscribe, rate, and review wherever you get your podcast. Heart valve disease is a fairly common cardiovascular condition when a person maybe can be born with a valve problem or develop symptoms later in life. These may include regurgitation or leaks in which some blood flows backward through the heart because a valve doesn't fully close. Stenosis, which is a valve narrowing or stiffening that makes it harder for your heart to pump blood. And then there's atresia, which is the absence of a properly formed valve. Joining us today are Dr. Ashvarya Mangla, a structural interventionalist, and Dr. Sudhir Mungee, Director of Structural Heart, to discuss how OSF HealthCare Cardiovascular Institute in Peoria, Illinois, has built a reputation as an industry leader in heart valve treatment. First of all, thank you both for being with us.
Sure. Thank you.
When we think about a heart condition, we may naturally think that it's open heart surgery. That's what I think a lot of people still in this day and age go to. That when we're talking about dealing with the heart, you're cracking the chest open and we're doing open heart surgery. And that certainly is not necessarily the case anymore, is it? There's a lot of different things. So give me the overview of why we think that and then what the reality is.
Yeah. Well, first of all, thank you, Sherry. It's always nice to see you. I take you back in times a little bit because it's a lot of change that we have seen in a decade only. So come around 2011 and 12, the new technique of replacing heart valve without open heart surgery got approved, FDA, because of an innovation called as transcatheter aortic valve replacement, which is basically putting a new valve through your groin artery and pressing the old valve. So there was a lot of excitement and buzz about it. The good thing is OSF wanted to be in the front runner to adapt a technique which was going to define how we take care of things. We were actually very lucky to embrace this technology as early as 2012. In fact, the very first TAVR that we did was December 12, 2012, 12. And fast forward, we are in 2026. We have done over 2,000 TAVR procedures. The concept is minimally invasive procedure. We've come a long way in this technology. Previously, it used to be general anesthesia. Now you do it under minimal anesthesia. Previously, there was a skin cut to put the big tube. Now, there is a pinhole and you put sutures from outside in. Previously, we could do 2 valves in a day. Now we can do 5 or 6 in a day. Patients go home the next day. So I think the technology started in the field of structural heart division, and then it brought in other things. Aortic valve was the first to start, and then came mitral valve or tricuspid valve. So
yes. And as Dr. Mungee mentioned, 2012 was a pivotal year overall because the transcatheter aortic valve replacement opened doors for a completely new field in interventional cardiology, which was a structural heart disease. It essentially revolutionized how we take care of these patients. And aortic valve took the lead, and now the technologies and innovation kept on pushing the boundaries. And now the next came addressing the leaky mitral valve, where we could now go from the leg and essentially create a pinhole in the heart and address the leaky valve by putting a clip on the valve, completely avoiding an open heart surgery. And depending on what the patient has, this is often the frontline treatment. Again, it all depends on what the patient has. For a majority of patients, open heart surgery is still the way to go, but a lot of patients who in the past we would say, we are sorry, we can't do anything for you, their lives are now transformed.
I was just going to say, for patients, I mean, I know there are patients who might not have had another choice because they couldn't have
Yes.
survived an open heart
Correct.
surgery, because that's extensive. That's a
Yes.
lot. And so are you finding, I mean, I know as we get older, we get a lot more of these problems, correct? So this is an
Yes.
older population.
Right.
So is that where you see the biggest advantages, is that we're able to take care of these older people that maybe previously were active and now lose some of that because they didn't think he had a choice, and now you're giving that back to them?
Yeah, so, if you think about it, it's an age prevalent problem. More than 65 years of age are typically the patients who get degenerative valve disease. And when the first trials came, it was trials on patients who are considered high risk or inoperable for surgery. When you can't get anything, could you get a TAVR valve? Well, that trial showed everything positively towards these valves. Then came trial, if we could do it on high-risk patients, could you do it on intermediate-risk patient? Again, the trial was positive in favor. And then came low-risk patient. That's when things started to change and said, okay, it should be a patient-centric decision-making where even low-risk patients can get that. As Dr. Mangla said, I think for mitral regurgitation, surgery is still kind of the first option, but not for the high-risk patient.
Right. Not for the inoperable and the high-risk patients, patients who are in cardiogenic shock with failing hearts who may not even survive the surgery. So for them, this is a transformational procedure. Similarly, patients who have advanced heart failure, who are on maximal medicines, still have a significantly leaky valve, their quality of life is significantly impacted. And again, this procedure is minimally invasive. You come in the morning, get it done, takes about anywhere from 2 to 4 hours depending on the anatomy, and you go home the next day.
Now, okay, so aortic, I understand what that does. Now, with the MitraClip and then the TriClip, let's talk a little bit about just structurally how all that works and connects and how a patient may present. So, where is the difference on how these affect people?
Sure. So I think we'll each take one of the clips, okay? So you just get the
Pick a
flavor
clip.
of it.
Okay.
I think it is important to first understand majority of these patients, how they present. For aortic stenosis, the common three things that patients should be aware of is either chest heaviness, chest pain while doing something, shortness of breath, or syncope, passing out. Any of these symptoms, your risk of mortality is more than 50% in less than 2 years. Many times during educational talks, I tell this is the worst cancer to have. Compared to all cancers in the body, aortic stenosis is probably the most lethal, and there is a good cure for it. It is just about awareness that we need to create. As far as the mitral clip is concerned, most of these patients present with heart failure, mainly shortness of breath. And tricuspid regurgitation.
Yes, and these patients, again, it all depends on where the valve is. Both the mitral and the aortic valve, they're on the left side, and left ventricle is a much more important. No chamber is less important, but left ventricle is a much less forgiving chamber. It is much more important for the body. The right side is a little more forgiving. The pressures are less. So the presentation for right-sided heart failure and tricuspid regurgitation is a little different. Patients present with fatigue, lassitude, poor appetite because they have fluid buildup in their belly and food absorption is affected, leg swelling, and those sort of symptoms. So more of edema, weakness, fatigue, tiredness that just builds up over a period of time. And what we want to catch these patients before their right ventricle starts to fail. Because once the right ventricle starts to fail, then we are limited by how much we can help, because in a failing right ventricle, the tricuspid valve actually serves as a pop-off valve. So you don't want to fully close it. So what's important for the patients to know is notify your doctors upfront about the symptoms you're having, the swelling, the lassitude, the fatigue. It may not all be part of the aging process, and there could very well be a leaky valve that could be causing this.
Yeah, one of the things that I think is very important to understand is there are two aspects of patient care: quality of life and quantity of life. And it's interesting, when you meet an 85-year-old, the choices could be different. When you meet a 65-year-old, the choices could be different. But as a physician or a provider, you look at the balance of both. sometimes it's all about the quality of life. When you have lived a very fulfilling life, the last thing you want is every 2 or 3 months to be in the hospital because you are in heart failure. You can't breathe, or you can't do things that you really like to do, be part of the family function, or visit a grandkid, or just lift the grandkid. The quantity of life is not that important for that person at that time, but the quality of life is. Also, think about it. I mean, we are all a society which should be accountable for healthcare dollars. And every time we get to a hospital with the same diagnosis, there is a healthcare dollar burden for something that can be prevented. So not only it prolongs life, but also gives you a better quality of life. So I think both these aspects have been well served, whether it's a TAVR or it's a MitraClip or a TriClip.
What are you hearing from patients? That brings us around to that point. So what are you hearing overall? I have to imagine they're thrilled, especially when you say to them, or they thought they had no other choice, and now you say, no, we got this. So what's the reaction?
I mean, satisfaction first thing. I mean, it's a burden lifted off their body that, hey, we have an option, we can proceed with it. And what we have been seeing is that all of our patients who undergo MitraClips, we walk them in the hallways the very next day. And we have been very good about our patient selection. All of our patients so far have said, I feel great. I cannot imagine that I am able to walk this much so soon after the procedure. And they are surprised that the recovery is so fast because, you're home the very next day and you can drive the very next day, and the results are rather instantaneous. So most of our patients have felt great.
Shelli, when you've gone through a procedure, you've been part of that for 2,000 valves, there are lots of beautiful stories. You can't keep a farmer away from the farm, even if you're 85. The fact that farmer can go back on that farm without getting huffing and puffing, they're going to be thankful to you. I remember a wonderful story of a professor from Bloomington who wanted to run a senior citizen marathon. You know how old he was?
How old?
98 years of age. And he was our oldest TAVR. He got the TAVR done, and then he came back with multiple medals to show that not only he participated in marathon, but he won many things. We didn't ask him how many of that age group are there in that competition. Having said that, I think this is the life that is the joy in their life, what they have been doing all their life to keep doing it. I think the gratification for us providers, but for the patient who couldn't breathe, doing simple things, going to the bathroom and you're huffing and puffing. Yeah. You can't imagine living life like that.
So let's talk about how all of this is placing OSF Healthcare on the forefront out across the country in some of the work we're doing in Peoria related to structural heart issues and heart defects and heart valves. Tell me about that.
Well, I think what started with one thing has now expanded into a big village. We are a full spectrum structural heart division. We do aortic valve disease, mitral disease, tricuspid disease. Dr. Mangla also performs PFOASD that he could talk about. But not only that, it's the complexity of these valve problems that we are able to deal with simply because of the experienced team we have. And clearly, it takes a village to get where we are. I'll give you an example that most times we go from the leg artery, but there are times when patients have very significant vascular disease that you cannot go from the leg. And the only options used to be in the past is either to go straight, what we call transapical through the heart, or actually do a sternum operation and go through the aorta. But our surgeons trained to do what we call transcarotid TAVR, meaning from the neck artery with minimal incision. Now we are probably the busiest center to give this alternative to patients where we cannot get from the leg artery. Dr. Sarangi and his colleagues worked on this, and we created a transcarotid TAVR program. So it's not just bringing program, but keep improving it to national standards right here in Peoria for our patients. And then, bringing the newer modalities like the clips.
Right. And as Dr. Mungee was mentioning about teamwork, it takes a village. I mean, the advantage of being at OSF and especially at St. Francis in Peoria is that it's a comprehensive care center. I mean, we have a very good stroke team, and we are able to collaborate with our stroke neurologist, and we have a very comprehensive PFO closure program where our neurology colleagues evaluate the patient and then they send the patients to us, and we have a collaborative meeting and we decide whether or not this patient's stroke was related to the PFO and will they benefit from PFO closure. And on the same front, I mean, we have Jump Simulation Center. For a lot of our complex structural cases, we have done their CT imaging and we have sent it over to Dr. Bromlett in the Jump Simulation Center, where they have created a 3D virtual reality simulations. And using the data from that, we have been able to make decisions. And we have pushed the envelope. We have presented some of these complex cases at national and international meetings. Our fellows have done that.
Yeah, and they probably sit there and go, because everybody, wait, this is happening in Peoria?
Yes.
And you say, yes, come join us.
Yes.
Actually, there are a lot of people who want to come and train here simply because of the volume that we have. I think our geographic location, I think the reach of St. Francis, I think the team that has been delivering the care for so many years now, it's been more than a decade, it speaks for itself. The credibility is out there in patient care, and you know how we approach each patient, every time.
Yeah, and you're correct. And no offense to all the physicians on the team, because it is about you, but there is a huge multidisciplinary
Absolutely.
care team that, like you said, it takes a village to make this happen from pre-op to post-op to on.
I mean, our patients get to see us first because they're referred by somebody. I'll just walk you through how many people and what is involved. So you are a patient who either has a symptom or somebody told you have a heart murmur. That is when you want to really get going to find out what can I do about it. Your physician refers you to a structural cardiologist like Dr. Mangla, Dr. Barzalo, myself, and we evaluate through cardiac imaging. So that's the first step. Echocardiogram or CT scan or something like that. Then patients undergo angiography. So now the cath lab staff is involved, where patients get a left and right heart catheterization. Once this happens, there are times patient has to see an advanced heart failure specialist or a cardiac electrophysiologist. So we have that as part of team. Then patients get to see a cardiac surgeon if needed. Or in most of the cases, to get their blessing that this is the right choice and not open heart surgery. This concept is heart team discussion. We have dedicated cardiac anesthesiologist for situations like that. And then our post-op staff, the staff that is recovering these patients, the cardiac rehab people, the people who are looking at registry. Every patient, every complication or every success is documented by a registry. So it is tremendous number of people and divisions that come together to make, a successful outcome for every patient.
So on a personal level to both of you, when you both started down medical school paths years ago, did you ever think that this is where your work would take you and what you're doing now and what you are involved in?
You go first.
Okay. No, I did not think that. What I wanted to do was I wanted to provide good ethical care to my patients. And, it's an evolution. It's a stepwise evolution. As a young medical student, your goals are different and that goalpost keeps on shifting. As a young medical student, all you want is get the knowledge, get good at diagnosing things, and then next step is a residency. As a resident, you want to be the best. You want to again gain knowledge and choose a field and be good at caring for the patients, be able to provide good care to the patients. And then the goalpost shifts again when you are a fellow that, hey, this is a field I'm specializing in. I want to be the best at it. I again want to give the best care to my patients. And then, you want to have all the building blocks so that wherever the field takes you, wherever the field evolves, you want to be in a position where you can evolve with the field and be at a place where wherever the field is, howsoever advanced it is, those care models can be applied to the patients. So I think it's a building block and the building blocks remain the same. The basic goal remains the same. And then wherever the field evolves, you go with that.
Yeah, I mean, I think it's well said. I'd be honest with you. Yeah, none of us really thought even 10 years back that we could be doing this. But, the more you do things, that the more you realize there is so much more to be done. We didn't know that this could be done. And now we know that there are so many things that we actually don't know. So it's an humbling experience. It's gratifying experience. But I think there is one more thing. As a physician who's been doing things for 20 years now and TAVR for more than 10 years, I've realized one thing. When not to do things. That is actually sometimes way more important. Just because you know how to fix things doesn't mean everything needs a fix. I think you get to know who's behind the heart. It's one thing to put a stent or a valve, but to connect on a level that is beyond, technology. These procedures give you that time, because when a war veteran comes to your office, you don't want this to be a 15, 20-minute consult, because you really want to know what they have done and what we can do for them now. So there is a lot of philosophy, and I don't mean to just sound it. I like to practice that, because that's really where the fun of medicine is, which is kind of getting lost at times just in computers. But these kind of procedures, because they are so comprehensive, they are so involved, it almost demands that we give that time to our patients to get to know the family, so that, God forbid, if there is something that doesn't go right, who are we talking to? Who are our partners? Our patients and their families are our partners in this. So I think there is a lot of growth, not just technology, but as a physician, as a team, as a hospital, as a system.
Okay, so final question, as you talk about as the evolution goes. So where are we heading? What's on the horizon looking in that crystal ball? What do you see coming down the pike?
Go ahead.
Okay. So coming down the pipe, I think the field is only set to grow, because minimally invasive procedures are safer for the patients and they're easier on the patients. The question is, how do we refine them even more? And as Dr. Mungee mentioned, there are still a lot of unknowns. I mean, the TAVR is for predominantly aortic stenosis. I mean, we are just now getting percutaneous valves for aortic regurgitation. MitraClip is for a leaky mitral valve, but what about a stenotic mitral valve? How can we get a new mitral valve in the mitral position percutaneously? And similarly, for a tricuspid, how do we get a tricuspid valve there? And what about patients who have ventricular septal defects? So there are still a lot of unknowns, and there is still a lot of evolution that's happening. The field will only grow, and institutions such as St. Francis, which has a good support system, good network system, and which has the vision to grow, these procedures will only continue to benefit patients in such institutions.
Yeah, I mean, I think there are two aspects of this question as far as I think, Shelli. One is what is out there going to be. It's going to be bigger, better, easier, more deliverable, and more accessible. All of that is good. But then there is something that we need to reflect back on. Why are we having so many problems? Just because you're going to keep finding more tools to fix a problem, I think it should give you time to say, can we prevent many of these problems? So, yes, many of these problems you cannot control. They're part of aging and all that. But there are many problems in the cardiology world which actually can be prevented. Nobody's paying attention to that as much, or it doesn't get the footage, because is there any growth to say, I'm delivering lifestyle and I'll get paid more? No. So dollars are being projected where the companies are or the industry is. But how about living healthy, sleeping better, stress, no smoking, decreasing stress, the activities, the kids, how different part of our societal culture related to preventing cardiovascular disease could be addressed. As we keep thinking about the ceiling on the other side, we need to keep looking at the back and say, how about not going to that spot with those many problems? So whether it's coronary stent or needing surgery and things like that. So I think, it is important to know both. But the future of structural interventional cardiology is extremely bright, simply because technology is going to keep advancing. AI is coming into structural division now.
That's
Imaging.
a whole other podcast.
So there are a lot of things coming up, but I think we should not forget to address the preventative aspect of cardiology and cardiac diseases.
Yeah, or the next time I talk to you will be because that age starts shifting younger because of those things piling up, and you're not just treating older people,
Right.
You're treating younger people.
Younger and younger people.
Yeah. And so let's hope we don't have to revisit the topic on that. Dr. Sudhir Mungee, Dr. Ash Mangla, thank you for taking time out of what I know are very busy schedules to be with
Thank
us.
you for having me here.
Really a pleasure.
And thank you for joining us as well. And be sure to check out all of the episodes at osfhealthcare.org/accelerated.